Thank you all so much for coming. My name is Emily Austin. I am this session's presenter. I'm an emerge physician at St. Mike's Hospital in Toronto, and I also do a few shifts in the Niagara region if anybody works down there, although not many. I also work with the Ontario Poison Centre as a toxicologist there. So I have no disclosures otherwise. And just as an overview for today's talk, the Ontario Poison Centre covers toxicology call for the province of Ontario, as well as the province of Manitoba, as well as Nunavut. And I did my training in toxicology through the Canadian program, so did a lot of time at the Ontario Poison Centre there. And what the coolest part about it was seeing all the cases that really emergency physicians and my colleagues and all of us here, as well as emergency nurses and first-line paramedics are sort of managing in the community, and hearing about all these cases. And I remember in my first week of training, I thought to myself, the day I see a toxic alcohol will be such a rare day. And then we're seeing them almost several cases a week at OPC because we cover such a broad area. So the cases that I'm presenting about today are cases that have all been managed by emergency physicians and in emergency departments. There's going to be 3.5 cases. And I will, just right off the bat, I'll tell you that I don't expect that these are going to be cases that you'll necessarily see in the next year. I ran the cases by one of my colleagues, who's also a toxicologist, and I said, I'm giving this talk to a bunch of sort of frontline emerge staff. Should I be talking about cocaine-related agitation and stuff like that? And he said, I think everybody's heard that a lot, although I'm happy to talk about it at the end if anybody wants to. But we're going to talk about some things today that I think that there's a good chance you'll see in your career or over sort of a 10-year period, that when we got these calls at the OPC, they caused me to sort of pause and give me a chance to think about them a little bit. I have very formal objectives, but I'm going to skip this slide. I interrupt people regularly. I don't know if this is the right room to do it, but feel free to, and we'll try to make it work. I thought we were in a bit smaller room, so I've got one sort of discussion point, but I think we'll just make it work. Case one. Case one is a 38-year-old female, and she actually presents to the emergency department 45 minutes post an ingestion. So she lives really, really close. She's a healthy woman, history of bipolar disorder, nothing else. And she says that 45 minutes ago, she took about 60 tabs. She took sort of 2 months worth of her Olanzapine, 5 milligrams, and then a whopping amount of acetaminophen, about 500 milligrams. And she's 45 minutes in the ED, brought into a room really, really quickly. These are her vitals right at the bedside. So she's GCS 15. The only real notable thing is she's got a tachycardia. Her blood pressure's okay. She's afebrile. And just to not belabor the point, if we do a complete physical exam, her exam is essentially benign and non-contributory. She's 45 minutes out of this ingestion. Now, it's a pretty significant ingestion, just to go back. She's had about 60 tabs of Olanzapine. And so the emerge doc who calls us, it's about 50 minutes, maybe 55 minutes post-ingestion, and he says, should I be initiating gastric lavage in this patient? And I thought it was a really interesting question and a pretty good question because we don't often see people within that first hour. And you will see people within that first hour, but it's not that common. And there is this thing, has anybody in the audience ever done gastric lavage? Yeah, for sure. In my training, I finished a few years ago, gastric lavage was not something that was done very much. And we'll talk a little bit more about it today. Gastric lavage fits under this idea of decontamination of a poison patient. And so what's happening with decontamination is we have this patient, they've taken something really toxic. In order to see the clinical effects of that, it has to get absorbed into the bloodstream. And what we try to do with decontamination is to prevent absorption so that we can prevent the clinical effects. And there's lots of ways we have to do this. Has anybody ever used Ipecac? Yeah? There are likely people who have used Ipecac. Can you shout out, when was the last time you would have used Ipecac? Okay, yeah, the 80s. I have never seen Ipecac used. It's sort of been crossed off this list for decontamination. What it is, for people who don't know, is it induces vomiting in people. And it does it, they think, more centrally, actually. It acts sort of in our chemoreceptor trigger zone to induce vomiting. So ipecac is out. Activated charcoal, I think most people are probably familiar with. You give activated charcoal, and along the whole GI tract, it's going to hopefully absorb to specific toxins, prevent them from getting absorbed into the body. Whole bowel irrigation, it's a bit of a complicated topic, but it is done in the right situation where you're sort of giving a patient a huge amount of PEG, usually, to help them work through their GI tract. And then the last one here, and they'll pass a toxin from below. The last one here is gastric lavage. Gastric lavage is indicated when there's something in the stomach. So specifically, you gotta have pills in the stomach. It's not gonna act below the pylorus because it's something that we're doing to a patient. So what really happens is that you take this large orogastric tube, and this is specific for adults. In a pediatric patient, you'd need a different size were you to do it. But a large orogastric tube, and they kind of quote between like 36 to 40 French. There's a reason for that. We'll talk about it in a minute. I'm not going to go over the details of the procedure, but the gist is that you're going to put this orogastric tube into the stomach. And when you put it in the stomach, the next thing you want to do is turn the patient over on their left side, and you irrigate with tap water. About 200 cc's, 250 cc's, and then you drain the exact volume out. And what you're hoping to get with gastric lavage is that you're hoping to see some pill fragments or some sludge come up. So you're preventing any of that from going past the pylorus. This is a great picture, except I would only ever do it if my patient's intubated because of some of the complications. And the PPE is like perfect. This is clearly a perfect patient that's fake. But I would make sure that your patient's intubated. So the question is gastric lavage even gonna work? Some people in the room have done it. It's not that common anymore. Will it even work? Well, like I've said, it's gotta be within the stomach. And so this 60 minutes is a pretty arbitrary number, but if you don't have any pills or any fragments of drug in the stomach, there's absolutely no point in doing gastric lavage. And we don't really know when that exact time point is. 60 minutes may be true, and we kind of use that as an arbitrary number, but the truth is that they've had studies that have been done where if people take drugs that slow the GI tract, anticholinergics, opioids, things like that, that there's drugs in the stomach well beyond, ASA is another common one, there's drugs that are in the stomach way beyond that 60-minute mark. But if there's anything past the pylorus, there's no point. The second thing is that if you look at the size of the holes in your tube, your pills have to be able to fit up the tube or the pill fragments. And that's why you need such a big tube. So it would be great if we could just go ahead and put in a 22 French or something like that, a smaller NG tube. But it probably won't work for most of these things. And understanding the pill size of what you're dealing with and whether those will fit up the holes of your OG tube is part of the decision point of making this. Beyond the question about whether it would even work is the question of should we even be doing gastric lavage. There's lots of complications associated with it. You can imagine you're putting this huge tube down into somebody's stomach, esophageal injury. The big two up here are going to be esophageal injury and pulmonary aspiration. Other things that have been reported, though, are that people can become slightly hemodynamically unstable, and especially in pediatric patients. They've given patients, they've had electrolyte and fluid abnormalities and disturbances from doing that. In peds, it's more reported that you become hypothermic. There's lots of complications. And when you aspirate some of this stuff, patients never do well. So the big toxicology organizations have put out position statements starting in 1997, reviewed in 2007, and then again in 2013, and they kind of looked at all the evidence and they said, you know, really, gastric lavage is not something that should be done routinely, if at all, in the treatment of the poison patient. The only thing is that they don't completely say, never do it at all. They kind of leave it open, which is why this emerge doc, I think, called us in the first place. He's got this ingestion, it's 60 minutes, it's a huge amount of olanzapine. Should he be doing it? And what the position paper sort of, looking at all the evidence, said is that we've got this balance, and that in a certain patient, that balance of risk-benefit may be pushed in favor of going ahead and doing it, going ahead and giving gastric lavage. What might shift the balance? If you have a patient who's taken a really lethal ingestion of a drug, so their drug that they've taken is really lethal, we don't have a good antidote for it. This is a drug that will not be bound to charcoal, either because the properties of the drug, or maybe they've taken such a huge amount that we'll never get enough charcoal in there. The other thing is, if that drug, we can be fairly confident, is still in the stomach, either because it's pretty recent, or maybe it's within an hour and a half, but it's one of these features of drugs that will slow the GI tract. Maybe under those circumstances, we can use our clinical judgment to sort of say, maybe there's an indication to do it here. This patient's gonna get really sick and will probably die without it. Consider these cases. So acetaminophen, there's these concept of a massive ingestion of acetaminophen, 500 milligrams of an extra strength tab. Let's say I've got 100 tabs up there. Let's say it was 200 tabs. Ever an indication for gastric lavage? Not really, ever. NAC and acetylcysteine is a beautiful antidote. If you can start that antidote within 8 hours, you're pretty good. You'll never need to do gastric lavage. What about propranolol? Anybody seen a propranolol overdose? Yeah. So I put propranolol up there. My boss at the Poison Center, who's the medical director, Margaret Thompson, the last patient that she gastric lavaged was a propranolol overdose. Propranolol is a nasty beta blocker. It is the nastiest of all the beta blockers because it also causes sodium channel blockade. Propranolol, you can get really sick. This patient came in for Dr. Thompson within the hour of ingesting a propranolol, and she gastric lavaged the patient. He got certainly sick, but he ended up living. Propranolol you might consider it for in the right circumstance. Fluoxetine. Fluoxetine and SSRI, you don't get that sick. It would not fall under this type of lethal ingestion. You may if you take enough, like you could definitely get really sick, but you wouldn't. Anybody seen colchicine ingestion? Colchicine ingestions are not exciting emergency medicine ingestions, but these are patients that can get very sick and can die, and we don't have a lot of options for treatment for them. If you see a colchicine ingestion early on, we'd encourage you to reach out for supports and to call some people, i.e. the Poison Center, but I don't want to advertise. And this would be something that I would consider in the right patient again, okay? Anybody seen those iron gummy pills? What if you had a massive ingestion of some of those, like somebody's just loving them? The problem with those iron gummies is that they're gonna clump together. They're not gonna easily fit up the holes of your OG tube. So I kind of just put that up there to introduce this other consideration that we have to have when making the call about whether we wanna go ahead and do gastric lavage, which is whether it's gonna actually even have a shot at working. Let's return to our case. We have an olanzapine ingestion that's pretty significant, also acetaminophen. Acetaminophen is like, it's an interesting toxin, but we're not gonna talk about it at all, I promise. So we're gonna take that off. She's tachycardic, but otherwise okay. She's here, we're within the hour. So olanzapine's an atypical antipsychotic, and I first started learning about antipsychotics in medical school when you learn about all of the different receptors that these drugs hit. And the truth is that in overdose, these antipsychotics really are just an extension of the clinical effects that they have. Not every antipsychotic, despite what I used to think, is identical to each other. Some antipsychotics target the muscarinic receptors a little bit more. Some of them target the alpha adrenergic receptors, and they're gonna give you hypotension a bit more. But in general, you're just gonna get an extension of the clinical effects that you normally see. So with olanzapine, it has particular affinity for your alpha-1 adrenergic receptors. You might get a bit hypotensive. For your histamine receptors, you're gonna become sedated. And for your anticholinergic receptors, you might see a bit of anticholinergic symptoms or delirium. As well, whenever we're thinking about these, always add in NMS and dystonias and stuff like that. So if we look at olanzapine, I can tell you that death with antipsychotic overdoses is very rare. This I would not count as an lethal ingestion. Furthermore, it is adequately bound to activated charcoal, She's taken a pretty big dose, so we might not be able to meet the 10-to-1 ratio. But certainly, it doesn't meet all of these criteria. Yes, it's a recent exposure. There isn't really a specific antidote for olanzapine, but its toxicity is going to be sort of a clinical syndrome of stuff that we can manage. So this case resolution is that she did actually get sick. We said don't go ahead and do a whole bowel, but an interesting thing to think about in the right patient. 2 hours post-ingestion, she was intubated for decreased LOC. Activated charcoal was given through an NG tube at that point, 2 hours after, for whatever it was worth. N-acetylcysteine was started based on a toxic 4-hour Tylenol level. She gets admitted to the ICU for 48 hours, mildly hypotensive, but ultimately she's discharged home on day 9. She did well. So the take-home points really from case 1 is that decontamination of the, and I didn't really get into this, but we will never have a clear-cut answer of when to decontaminate a patient and how to do it right. I think that it's us as the first-line staff who can sort of integrate this information and say, maybe I should be doing it in this time. And I actually thought that this doctor was really thinking appropriately to be considering doing it in this case. Gastric lavage is a form of decontamination, and in a small subset of patients, it may be the right thing. It often won't be, but we can consider it. We'll go on to case 2. So case 2 is a 30-year-old male, and he's found decreased LOC at home. Around him is found buproprion sustained release bottle, and they estimate that about 45 tabs were missing. EMS is called, and with EMS en route to hospital, he has 2 generalized tonic-clonic seizures. Bupropion is one of the most interesting drugs that I am familiar with right now, I think, for me. It's an atypical antidepressant, so it has lots of different indications right now. It's also being used for smoking cessation and stuff like that. And it's an atypical antidepressant. It was actually first released in 1985. And when it was released at a dose of about 600 milligrams. And what happened was that they started treating, in a study, these patients with bulimia, 55 patients, and 4 of them at therapeutic doses. They were not overdosing on their bupropion, but 4 of these patients started having seizures just with therapeutic dosing of bupropion in 1985 at 600 milligrams. So they quickly pulled it from the market. And then in 89, they reintroduced bupropion, but now our max dose is 450 milligrams a day, and it's shown in therapeutic dosing to not be associated with an increased risk of seizure. What's atypical about it is that you tend to not get some of the sexual side effects that you do, or some of the other side effects that you get with SSRIs. It can be more of an activating. And part of why it's a little bit activating is bupropion. My whole life, people have been showing me comparable structures, and I'm like, that kind of looks the same, but not really looks the same. The point here is to sort of appreciate that there's an amphetamine structure that has a backbone to it, which is the ring and then that carbon chain. And bupropion shares a similarity with that amphetamine backbone. Bupropion technically is actually what we call a synthetic cathinone, which is a subset of the amphetamine class of medications, which is why it can be a little bit activating. It acts on your norepinephrine and your dopamine receptors and stuff like that. Because of these factors, has anybody heard it called poor man's cocaine? Yeah, people are crushing it and snorting it. And if you crush it and snort it, you'll often, one of the side effects would be a seizure, but it doesn't tend to be long-lasting because you've been completely exposed to the drug all at one time. So when overdosed with bupropion, you would expect to see seizures and some cardiotoxicity. That cardiotoxicity looks like a wide QRS. You can also see wide QTC. What's annoying but interesting and kind of crazy is that wide QRS is actually not caused by sodium channel blockade, like we get with TCAs and stuff like that. It's a completely different mechanism. It involves intracellular gap junctions. If I think I've got a bupropion overdose and I see a wide complex tachycardia on an ECG, I am still going to give bicarb, but it tends to not work. Okay? It's a different mechanism. Bupropion, people can get sick. Our patients been found with lots of bupropion around them. In the emergency department, they're tachycardic, they're hypotensive, they have a third seizure. They develop a wide complex tachycardia. The emergency staff gives bolus doses of bicarbonate, they give some magnesium, and they give calcium gluconate. Despite their best efforts, the patient loses a pulse. They had, I believe, tried to defibrillate that rhythm, but they didn't get anything, and they continue down the PEA algorithm. And the question is there anything else that we can do for this patient? So when you dive deep into ACLS, the part 10, in terms of the special circumstances, talks about the role of intralipid emulsion therapy in cases of drug toxicity. And the statement in the drug toxicity one is that it may be reasonable, which is very vague, but it's all we're ever going to get, to administer intralipid emulsion therapy to patients with drug toxicity who are failing standard resuscitation measures. So what is intralipid emulsion therapy? So intralipid is the proprietary name, it's the brand name, but it's what we all call it. And basically it's this mixture of triglycerides and phospholipids. And when you have the patient that you need to administer to, you're going to administer it as a bolus, and then you're going to start an infusion going, okay? And why it would work, we don't really know. It does not always work, which we'll talk about in a minute. But the theory behind it involves a few concepts, one of which is the lipid sink theory, which says that all of these triglycerides surrounded by phospholipids are going to make this kind of this additional compartment in the blood. The drug will concentrate in that compartment and pull drug from the tissues. There are some thoughts that maybe these intralipids, the heart is dependent on free fatty acids for energy metabolism at baseline. Maybe it's going to provide more metabolic substrate for the heart. And then they've also shown that it can act on calcium channel the calcium channels. We don't really know. The best guess out there is that it's probably working like a lipid sink, where it's creating this other compartment to pull drug away from the tissues, and then we just eliminate the intralipid. Two questions to ask ourselves about these intralipid emulsion therapies. When should we use it? Should paramedics be carrying it? They see this bupropion with seizures, should they be giving it? And number two, what drug toxicities can actually be treated with intralipid emulsion therapy? When it should be used. So ACLS is very clear that they say it's patients who are failing standard resuscitative measures. This is not a first-line therapy in any circumstance. And the reason for that is that you look at all the adverse effects that are associated with intralipid emulsion therapy. Most of these have to do with patients who get way, way, way too much. So for example, I've said that you give a bolus dose and then an infusion for about 30 to 60 minutes. That infusion has been continued on for like hours in a patient who maybe got Roski, and they've shown that they can get lots of different complications for it. But lots of complications associated with it. You can imagine it might be harder to ventilate a patient. It may interfere sometimes with ECMO and with hemodialysis, which are all modalities that some of these patients need, right? The biggest adverse effect associated with intralipid emulsion is it makes your serum really lipemic. And that probably isn't something life-threatening, but it can make it very difficult to monitor your patient in the subsequent hours, assuming that you're able to get Roski or that you resuscitate them a little bit. It can really derange all the blood work, and it doesn't do it in a clear-cut way. I can't tell somebody who I'm talking to, once you've given intralipid, your hemoglobin will always be unreliable, but your calcium should be reliable. It messes everything up for a variable amount of time. So because of all these adverse effects, really ACLS says that we should be using this as a last-ditch effort when you're failing all your other standard resuscitation mechanisms. The next question is, yeah?
When you say last-ditch, do you mean last-ditch like they're already dead, or they're white complex QRS and you've given all these things?
Yeah.
And it's a white complex tachycardia, they're just still barely alive?
Yeah, that's when I would give it. I think of it as my peri-arrest. It's part of my peri-arrest. If they've lost a pulse and I've done everything else, I'd probably do it then too, but I'm not giving it to somebody that I haven't tried to push bicarb, I haven't tried to give magnesium to. Yeah. I anchor onto peri-arrest, but I recognize defining that can be a bit tricky sometimes. What drugs can we give it to? Could we give it to any drug toxicity that somebody takes? I've mentioned that we don't know for sure, that the best way that this is working is from this lipid sink theory. So I'm not trying to get too scientific here, but this means that certain drugs are going to have certain properties that might be more amenable to intralipid. And this is just to explain it. There is something that every substance has a property to it called the log P. And the log P is done by people in a lab who take two different liquids. One is fat, so octanol, and the other is water, and they see where the drug distributes. And based on where that drug distributes, you're going to get your log P. And if it distributes more into the fat, you're more lipophilic, okay? And that number is quantified by log P. I Google it for drugs, like you cannot remember all of them. Furthermore, they change with pH and stuff. It gets a little bit complicated, but the gist of it is that we think that it probably works better for drugs that have a positive log P because of that reasoning of the lipid sink. So bupivacaine is the first drug toxicity that this was ever reported in. In 2006, the people who have sort of capitalized on this, right, are our anesthetist colleagues. 2006, they're doing an interscaling block. And it went intravascular, and the patient develops local anesthetic systemic toxicity, seizing, cardiotoxicity, cardiac collapse. And they work on him with ACLS for about 20 minutes. And then this guy Weinberg, he'd been doing all these studies in animals. He goes ahead and gives a dose of intralipid. And then he runs an infusion. And after about 20 minutes, the patient gets Roski again, okay? The biggest evidence is with bupivacaine. However, it's been used in like 50 million other drugs, okay? And it doesn't always work, but they've tried it, and they've tried to report on it. Papers have been done, and the evidence-based recommendations from the clinical toxicology people are really that if you've got bupivacaine, there's the greatest amount of evidence for that. Next is other local anesthetics, mepivacaine, stuff like that. Is anybody from Halifax? There's a case in Halifax. Do you know of it? Yeah, there's a case in Halifax in the emergency department of lidocaine induced. So they were anesthetized, and it's going to be written up, and I have nothing to do with the case. So I'm not trying to steal Halifax's thunder. It's just a really great case of an emergency department. They were anesthetizing the airway with lidocaine. Wrong dose of lidocaine was given for various circumstances, and the patient developed local anesthetic toxicity, and they were resuscitated using intralipid. So this could happen in our emergency departments. In terms of other drugs other than anesthetics, amitriptyline and bupropion, there's a bit of evidence for, but it's not super clear cut. And then maybe calcium channel blockers, certain beta blockers. Cocaine is certainly one that, based on its log P, might have the property. We can support people in these decisions at the Poison Center. I think local anesthetic toxicity is definitely a take-home, and some of the others as well. This patient's coming with bupropion. So this patient gets a bupropion bolus. They're starting on an infusion, and after, I think, 11 or 13 minutes or something like that, Roski is achieved. So after you do it, CPR was ongoing. They needed to continue CPR. Roski is achieved. They are transferred to the ICU, where unfortunately they rearrest. However, it's an interesting tool to have in our toolbox. So I think the take-home points from this case for me are that bupropion toxicity is serious. Bupropion is not in the same category as fluoxetine or paroxetine. It's a different antidepressant. Intralipid emulsion therapy is useful in life-threatening toxicity, for sure in local anesthetic systemic toxicity, and there may be roles for it with other drugs, such as bupropion and amitriptyline, some of the calcium channel blockers, as a last-ditch effort. So case 3. Case 3 is actually 2 cases, so it's like sort of 2 cases, sort of 1 case. And I think that patient A is actually 38, but it doesn't matter, because it's just to sort of compare them. So we've got this 30-year-old male. Patient A, He himself has called 911 for respiratory distress, and he basically says that he was huffing paint thinner all afternoon. Patient B, 911 is called for because he's unconscious, and found next to him is a bottle of carburetor cleaner. And I think we had some history that we knew that he'd been inhaling it. I don't know if the friend was with him who called, if this is what they had been doing. But anyway, 2 patients, they've both been inhaling something, paint thinner, carburetor cleaner, and they're both presenting a little bit differently. So patient A in the emergency department, GCS 15, he's not particularly cooperative. He's tachycardic, tachypnic, and his sat on room air at triage is 85%. He's got diffuse wheezing with increased work of breathing. This is his chest x-ray. It's not great, but it's not hideous, I suppose. He's certainly got something going on in the right side and bibasilar sort of increased pulmonary markings, I think. Our ultrasound colleagues could probably add to that. I think his heart looks a little bit big as well. This is the actual patient. I can't answer. Yeah, it appears like he did. Yeah. I didn't know that part of it, but yeah, he would have. It appears like it. I can tell you, so his previous x-rays did not look like this. Yeah, he's coming in acutely unwell. So the emerge doc starts Ventolin, nebulized Ventolin on him, and gets blood work and an ECG, which for the most part is okay. He's a little tachycardic, but it's sinus. The complexes aren't wide. So then they sit on him. He's getting a salbutamol. He's fighting a little bit, but he's reasonable. Patient B is GCS 11, a little bit tachypnic. He'll rouse a little bit, but he's got very slurred speech when he does, and his pupils are sort of 2 millimeters. We're not worried about opioids here, right? He's breathing. He's not really making sense. He's a normal chest x-ray. His ECG is essentially normal. They go reassess him after an hour and a half, and there's been no real change in his GCS. And so they get the blood work back, and he's got a pH of 7.19. He's acidemic. His bicarb is low. He's got a high anion gap, and the ethanol is negative. And I can tell you, the lactate is negative as well. I just didn't want to add it in. So there's something going on with this guy. So these are 2 patients that have come in with inhalant exposures. And inhalant exposures can happen. The way people do it is they can either huffing, bagging, or sniffing is all the same. Huffing, you can put it on a piece of cloth and you inhale it. Sniffing, it's direct from the bottle. You just sniff it up your nose. And bagging, it's in a bag and you're inhaling it. What's interesting about these 2 patients were both in their 30s, but it actually tends to be, if you look at the demographics or the epidemiology of this, it tends to be that inhalant exposures are in a younger population. These are legal products that they can purchase at Home Depot. Both of those, I think I forgot to add the references, but both of those, the paint thinner and the carburetor cleaner, those images were from the Home Depot website. And these are legal highs that tend to be younger populations, and they have quite an addictive quality to these substances as well. Inhalants are not always the hydrocarbons, though that's what we're talking about today. So hydrocarbon-based inhalants are like paint thinners, spray paint, glues, carburetor cleaners. Some of the deodorizers tend to be the alkyl nitrates, actually, which are poppers. But most of them that we think of are hydrocarbon-based ones. Lighter fluid, hairsprays, the list just goes on, okay? And then nitrous oxide is also, has anyone here done a whippet? My husband has once in his life, which is why I feel. Anyway, whippets are when you're inhaling nitrous oxide from the whipped cream containers. And so this is actually something that's done by lots of people, probably not us, but anyway, it doesn't matter. Nobody has to be honest. We've all done whippets. Anyway, it's when you keep doing them chronically that you can really get into trouble. But in general, these are what our inhalant exposures are, but the hydrocarbon-based ones are what we're talking about today, which is when you're really inhaling anything that's got a solvent in it, okay? And the hydrocarbon inhalants, I remember when I was learning about this, it was like aliphatic, aromatic, halogenated, all these different things. The truth is that even when you're inhaling it, they can be mixtures of lots of different things. So it's really hard to keep track of what you're inhaling. We kind of, if we know the product, we can trace it back. And then we know that some of these hydrocarbon inhalants have a few additives in them, which can be tricky. So carburetor cleaner specifically, which our patient B has inhaled, well, we think because it's at the scene, has methanol in it and is associated with methanol toxicity. Another interesting one is something called methylene chloride, which is in paint strippers, which nobody needs to remember, no, but the point is that methylene chloride is the hydrocarbon, it's gonna get metabolized to carbon monoxide. So we've had cases of carbon monoxide toxicity from huffing as well. Most of the time when people are doing this though, they're doing it because they want to try to get high. Most of the hydrocarbons, where they're gonna act is they're gonna act on our CNS and they're gonna start to get euphoric and disinhibited. But then if you get toxic because of your dose, you start to get CNS depression, and along with that comes respiratory depression. Before that, you may become ataxic, and there have been reports of seizures as well. I'll specify here that these are the acute clinical effects, okay? These aren't the things that people will develop after abusing these for a long time. As well, people can get respiratory toxicity from them, and this is actually mainly if you aspirate it, because it's gonna disrupt the surfactant. Sometimes people get hypoxic by completely displacing all the oxygen if they'll put a bag around their head, but that's a little bit different. But you can get respiratory pneumonitis. There's case reports of ARDS. This is fitting with our patient in patient A. He's got a bit of a pneumonitis right now. You'll often get a history that maybe these patients were gagging or choking or something like that. Our patient couldn't give us that history. The last one is this sudden sniffing death syndrome and cardiac dysrhythmias. Sudden sniffing death is that, like, anybody ever seen a case of it? I have not. It's that classic textbook case where the cops bust this kid, and the kid starts to run, and as he's running, his adrenaline surges, but he's been huffing, so his myocardium is being sensitized by all of these hydrocarbons that he has on board, especially halogenated ones, and he has a dysrhythmia. In fact, hydrocarbons can induce dysrhythmias, though, even without that surge of epinephrine. And that's because they'll interact with lots of our different ion channels. On top of these acute clinical effects, acidemia, reports of methanol poisoning, reports of carbon monoxide poisoning, and reports of methemoglobinemia. So basically anything, which I know is not helpful to us at the bedside. How do you manage these people acutely? I think if you have a history of huffing, you go with your clinical presentation. If they're altered and not resolving quickly, because people can get altered and it will pass very quickly. If they're altered, blood work, and I would consider including in that a VBG, osmolarity, and ethanol. This was picked up, they got lucky in patient B, okay? Because a VBG was done. It's not gonna show, maybe they would have picked it up on the electrolytes and the bicarb, that there was an acidosis and gone on to add all the other blood work. In the right case, just keep in mind that sometimes these things have carbon monoxide or can cause carboxyhemoglobin and methanol. Again, those will be associated with acidemia or decreased LOC. Respiratory distress is mostly just bronchodilators and supportive care. Sometimes these patients do need to be admitted for further therapy. There's not good evidence to support giving steroids or antibiotics at all. The problem is that sometimes they can get sicker. Sometimes they won't. And the big one, it would be the cardiac dysrhythmias, and this is when we talk about should we be changing our ACLS algorithms a little bit, not giving epi, maybe giving a beta blocker. So patient A, we'll just go back to and we'll get to patient B. Patient A got nebulized Ventolin and Atrovent 3 times over. After the SpO2 was about 91% persistent wheezing, but he looked a little bit better. He got more Ventolin, and he left AMA after 5 hours, which is what happens. He didn't come back, though. He came back a month later or something. He did not come back. If I had seen this patient at the bedside, I think I would have probably, you got to work with your patient, but considered admission because they can get these ARDS down the road. I mean, this guy did okay in the end. I think if he's sat at 91%, you kind of keep treating him a little bit. But patient B had a methanol level of 22. It was picked up on the gas. It was not ordered initially. This is a toxic level. Methanol toxicity is really sort of over 7 or 8. 22 is toxic. The threshold for dialysis is 15. This patient had no ethanol on board. They were given fameprazole and folic acid, which is how we treat methanol toxicity. They got admitted to the ICU. They had 1 run of dialysis. They may have had 2, I forget. They were discharged home on day 2. The take-home points from this case is that inhalant abuse persists, and that different inhalants have different respiratory effects, that they're not all going to be giving us altered LOC because of just the effect of the hydrocarbon in the brain. They can have other systemic toxicities that will do this as well. If you have an acidosis, you would consider, I would argue, methanol toxicity. I'll just summarize the 3 cases. Decontamination is such a tricky call because you have patients' ingestion histories are notoriously fraudulent. I don't know if that's the right word, are notoriously unreliable. But if you're at the bedside, consider decontamination in the appropriate circumstances. Intralipid emulsion therapy is a tool that I have in my pocket at the bedside when I'm resuscitating a really, really sick, poisoned patient. It's not got great evidence, but in certain situations, I'll certainly pull it out. And hydrocarbon inhalant abuse can present with lots of different, in lots of different ways that include a metabolic toxicity. Thank you so much for coming and for all your attention.